A placebo is one of the strangest ideas in medicine because it looks like treatment, feels like treatment, and is often delivered with the same seriousness as treatment, but it has no direct pharmaceutical action. It might be a sugar pill, a saline injection, a fake procedure, or even sham surgery designed to imitate the real thing. The key point is not that the placebo is magic. It is that the person receiving it believes, or at least may believe, that something medically meaningful is happening. That belief can change how symptoms are perceived, how the body responds to discomfort, and how researchers measure whether a real treatment actually works. Placebos sit at the intersection of biology, psychology, statistics, and ethics, which is why they remain so important and so controversial. The word placebo is usually associated with a harmless pill, but the idea is broader than that. A placebo can be any treatment-like intervention that lacks the specific active ingredient or mechanism being tested. In a drug study, it may be an inert tablet made to look identical to the real medicine. In an injection study, it might be saline instead of an active compound. In surgical research, it can involve a sham procedure where the ritual of surgery is simulated without performing the key therapeutic step. What matters is appearance and expectation. The placebo has to be convincing enough that the patient cannot easily tell whether they are receiving the real treatment or the comparison. Placebos are especially important in randomized clinical trials. When scientists want to know whether a medicine works, they need to separate the effect of the medicine itself from everything else that can happen when someone receives care. People may improve because their condition naturally fluctuates. They may feel better because they expect to improve. They may report less pain because they are being observed, supported, or reassured. A placebo-controlled trial gives one group the real treatment and another group a convincing inactive treatment. If the real treatment group improves more than the placebo group, researchers have stronger evidence that the treatment itself is doing something beyond expectation and context. For this comparison to work, the placebo should be as indistinguishable as possible from the real treatment. Researchers often try to match the color, shape, taste, packaging, schedule, and method of delivery. This is not done to trick people in a careless way. In proper trials, participants give consent to take part and understand that they may receive either the treatment being studied or a placebo. The goal is to protect the study from bias. If patients know they are receiving the real medicine, their expectations may influence what they report. If clinicians know who received the treatment, their observations may also become unintentionally biased. This is where the placebo response becomes important. In a placebo group, some people improve even though they did not receive the active treatment. That improvement is called the placebo response, but it does not always mean the placebo itself caused the improvement. Several things may be happening at once. Symptoms can naturally rise and fall. A person may enter a trial during a particularly bad week and then return closer to their normal level afterward. This statistical pattern is called regression to the mean. People may also change their behavior during a trial, follow instructions more carefully, or feel reassured simply because someone is monitoring them. The placebo effect is more specific than general improvement. It refers to changes produced by expectation, meaning, and the treatment context itself. If a patient expects pain relief, the brain can respond in ways that influence how pain is experienced. The ritual of care matters too: the white coat, the explanation, the pill bottle, the injection, the confident tone, and the feeling that a plan is in motion. These signals can shape perception. The body may release chemicals involved in pain modulation, and the patient may interpret sensations differently. The result can be real relief, even though the placebo has no drug action against the underlying disease. Modern research suggests that placebo effects are strongest for subjective symptoms such as pain, nausea, fatigue, and some forms of discomfort. These are experiences filtered through the brain, attention, emotion, and expectation. That does not make them fake. Pain is real, even when expectation changes its intensity. Nausea is real, even when reassurance reduces it. But this also explains the limits of placebo effects. A placebo might help someone feel less pain from a condition, but it does not shrink a tumor, kill an infection, repair a broken bone, or reverse a disease process in the way an effective medical treatment can. Placebos can influence experience, not rewrite biology without limits. This distinction is crucial because the placebo effect is often exaggerated in popular culture. It is sometimes described as proof that the mind can heal the body from almost anything. The evidence is more restrained. Placebos can produce meaningful changes in certain symptoms, especially where perception and expectation play a large role. But for many objective clinical outcomes, their impact is limited or not clinically important. If blood pressure, viral load, tumor size, or survival is the outcome, researchers usually need more than self-reported improvement. This is why serious medicine does not treat placebo as a cure. It treats it as a factor that must be measured and understood. The history of placebo thinking goes back centuries, but the concept became especially prominent in modern medicine during the 20th century. Earlier physicians noticed that patients sometimes improved after treatments that later turned out to be ineffective. As clinical research became more rigorous, placebos became a tool for testing claims. Instead of asking only whether patients improved after taking a treatment, researchers began asking whether they improved more than similar patients who received an inactive substitute. This shift changed medicine. It forced therapies to prove themselves against expectation, natural recovery, and the powerful human tendency to connect treatment with improvement even when the connection is not causal. Placebos also reveal how much the context of care matters. A rushed, dismissive interaction may weaken confidence, while a careful explanation can reduce fear and increase hope. This does not mean doctors should fake treatments. It means the human side of medicine has measurable effects. Communication, trust, attention, and ritual can shape symptoms and patient experience. An active medication may work better in practice when the patient understands it, believes the plan is credible, and feels supported. In that sense, placebo research does not only study fake pills. It studies the healing environment surrounding real care and shows why bedside manner is not just politeness. The ethical problem begins when a placebo is used deceptively in ordinary clinical care. If a doctor gives a patient a sugar pill while implying it is an active medicine, the patient may feel better, but the doctor has introduced dishonesty into the relationship. That bypasses informed consent, which is one of the foundations of modern medicine. Patients have the right to know what treatment they are receiving and why. Deceptive placebo use can also delay proper diagnosis or effective treatment. Even if the intention is kind, the method can damage trust. Once trust is broken, future medical advice may become harder for the patient to accept. Some researchers have explored open-label placebos, where patients are honestly told they are receiving an inactive pill, but also told that placebo effects can still occur. This approach is interesting because it tries to preserve informed consent while still using the psychology of treatment. Results vary, and open-label placebo is not a replacement for evidence-based care, but it points toward a more ethical lesson: medicine can use expectation, reassurance, and ritual without lying. The best version of this is not deception. It is transparent care that combines real treatments with clear explanations, empathy, and confidence grounded in evidence rather than false promises. The placebo is powerful not because it proves that illness is imaginary, but because it shows that healing is never purely mechanical. Symptoms are experienced by a person, not just produced by tissue. Expectations, fear, attention, trust, and prior experiences all shape how treatment feels and how improvement is reported. In science, placebos help reveal whether a medical treatment has a specific effect. In clinical care, they warn against deception while reminding doctors that communication matters. The real lesson is balanced. Placebos can influence pain and perception, but they are not miracle cures. They are a window into the complicated relationship between mind, body, and medicine. If you found this helpful, please like this video and subscribe for more explainers.